And the 1st of December marks the commemoration of World AIDS Day. We now speak to the CEO of SANAC, Dr. Thembisile Xulu, on this. Dr. Xulu, the connection failed us there, but I want to start that question again. We've made great advances in the drug and technologies pertaining to the fight against HIV, to the point where we've now stepped in the realm of preventative drug efforts rather than just responsive drug efforts. And even in the responsive sense, ARVs can now render people undetectable and then untransmittable. Very important advances, those. Yet we still have 8 million people in South Africa living with HIV, only 6.2 being on ARVs, and we see higher transmission rates amongst key populations, which are vulnerable populations. And we're losing the fight in some instances there. Why is that?
Thanks, Oliver. Apologies about that. So one of the greatest shocks for us from a systems perspective was the funding loss that we experienced at the beginning of the year from the US government. I think you will know that the US government was essentially seconding staff through NGOs to our public sector facilities. And when over 15,000 of those got retrenched, it did hamper our ability to capture data, our ability to be able to provide counseling, and also affected our community service organizations that actually render services to key populations like female sex workers, men who have sex with men. So there were instances that the system did experience a shock, despite the fact that we are heavily and primarily funded by the national fiscus. So because the government is not able to reach every particular patient through the public sector system, we do rely on communities to render some services. And when some of those CBOs were shut down, we did experience a few shocks. We also presented recently, Oliver, on Friday's plenary, the stigma index for the country. And we are still seeing a lot of internal stigma amongst people living with HIV, which tends to affect their self-confidence and their ability and willingness to seek health care, not so much because of the experiences at healthcare facilities, but more from an internal perspective. And those are issues that we are dealing with through rolling out programs like 6 multi-month dispensing, where people are able to get access for a 6-month period instead of coming monthly to a clinic, and to be able to then be suppressed and to then be able to not transmit, as you mentioned.
Let's talk about that stigma index, because internalized stigma is a real thing, but it's a psychosocial problem. But the remedy there seems to be rather practical and mechanical rather than psychosocial, in that we'll reduce the number of times you'd have to visit a healthcare institution, so maybe the stigma won't be so bad. Does it prove to actually work?
I think it proves to work in the sense that when communities lead and when people living with HIV that have actually gone through the experience are the ones that are leading the counseling, the services that I said actually almost collapsed, Oliver. It does make a difference in terms of somebody, once they get to understand that when I am undetectable, when I take my medication as I'm supposed to take it, then I'm not a danger to my sexual partner. If I'm a pregnant woman, I will not transmit to my unborn child, not during labor, not during breastfeeding. Then it actually increases the level of confidence. You are able to love, to live, and be happy because you know you are not a danger to anyone. Your life expectancy is almost the same as that of somebody not living with HIV, and it really does help to improve the level of mental stigma that people experience once they understand the efficacy of antiretroviral treatment and how it improves their quality of life. And we've seen that through the reports that our treatment action campaign has provided us, as the report was showing earlier, where patients, when they are not dealt with by us as policymakers, but by their peers, they really tend to engage on a similar level and respond quite differently, even from a mental health and support group perspective.
There's a more esoteric problem to solve, and that is that we're seeing increasing indicators, or at least the indexes on risky sex seems to be increasing across the board in South Africa, albeit not at the rate at which the transmission of HIV is increasing. Did we not perhaps shift our focus to to solving the medical problem rather than what seems to be a fundamentally social and behavioralistic problem?
You are absolutely correct, Oliver. The last time we had a successful social behavior change intervention was during the times of Khomanani, and that was way back in the early 2010s. And there is no doubt that we are now shifting our focus towards strengthening prevention, but even then, not just biomedical prevention. If there are 60 million South Africans, a success for me would be keeping the 52 million that are not living with HIV negative. And that is why, if you look at our latest strategies and interventions, we are moving more towards social behavior change and towards getting people back to simple things like the utilization of condoms. When you look at condom utilization, it's declined significantly in South Africa. And even the excitement around lenacapavir, because it's a biomedical intervention, if we can use lenacapavir to revolutionize the whole prevention intervention, going back even to the ABC, that is where our success will be, and that is where our focus is going to be moving forward to make sure that the behavior changes.
Are we seeing an increase in the uptake of pre-exposure prophylaxis, which is a counterbalance to risky sex behavior?
Absolutely. I presented this at the Durban conference, at the Public Health Conference in Africa. South Africa has actually the highest in terms of uptake of oral PrEP, which is what we offer now. We've got over 2 million people on oral PrEP, and 98% of our public health facilities offer pre-exposure prophylaxis. But don't forget, Oliver, that not all key populations are comfortable with coming to public health care clinics.
Yeah.
So those are still the areas that make access difficult based on the discrimination that people faced on their sexual orientation and sexual identity.
Yeah. Dr. Thembisile Xulu, thank you so much for your time. Really do appreciate it. And thank you so much for the work that you're doing.